Hi, I'm Dr. Avik Sarkar, Director of Bariatric Endoscopy at Rutgers Robert Wood Johnson Medical School. Today we'll be talking about a case of endoscopic sleeve gastroplasty. This is the case of a 36-year-old woman with a past medical history of type 2 diabetes and fatty liver disease. She is currently 210 pounds with a BMI of 37.3. She's failed diet and lifestyle changes. She has also undergone a medically supervised weight loss program with a nutritionist, but did not lose significant weight. She did not want a surgery, and I discussed pharmacologic as well as endoscopic weight loss options with her, and she elected to proceed with endoscopic sleeve gastroplasty. We start with an upper endoscopy to identify any contraindications to the procedure. In this patient, we did not find any contraindications, and we then proceeded with the sleeve. Here you can see us starting by the incisura at the anterior wall, using our tissue helix to grab the muscularis propria layer, then pulling that towards the overstitch device and deploying a full thickness suture. We start off at the anterior wall, usually take 1 or 2 bites in the gastric body, and then take our final bite at the posterior wall, which you're seeing here. We then step back 1 or 2 centimeters, take an additional bite here at the posterior wall, and work our way back up into the gastric body, taking 1 or 2 additional bites as we make our way up. Here you see us going again into the gastric body, and then finally we're coming up here to the anterior wall and taking our final bite with this suture. We then use our cinching device, which you will see come into view now, and we're using this to tighten the suture, and once it's tightened adequately, we deploy the cinch, which cuts the suture, and you can see the sleeve has started and has begun to form. So now you're seeing the second suture being used, and again we're repeating the pattern where we started at the anterior wall, going through the gastric body into the posterior wall. We are now cinching the second suture here. You can see again this is further tightening the sleeve and further continues to form the central length of the sleeve. What we've been demonstrating thus far is the U-shaped suture pattern. The purpose of this pattern is not only to reduce the width of the stomach, but it's also to reduce the length of the stomach. And this pattern allows us to significantly shorten the stomach also. Here you're seeing us continue the suture pattern throughout the stomach, working distally to proximally. We usually try to place anywhere from 6 to 12 sutures. I personally feel the more sutures you place, the better patients will do, as the durability of the sleeve is increased. The more stitches that are placed, the less tension is placed on each stitch, and I believe the less tension there is, the greater the durability will be. So here you see us continue the process, and as we continue to deploy our sutures, you can see on the right side of the screen is the lesser curve, and that's the area we're preserving, and that's the lumen of the stomach. And on the left side here is the gastric body, and this is the area we're closing up. So you can see here we're coming up and working our way very closely to the GE junction now. We try not to close the fundus, as we want to preserve the fundus to allow patients to feel satiety. And we just placed our last suture there, and now we're doing a final endoscopy to look at the central length of the sleeve, and you can see that the sleeve has formed nicely, and we've closed a little bit of the fundus but have left most of it intact. In terms of post-procedural care, this patient was observed in recovery for about an hour and then subsequently discharged home. She was sent home with Zofran as needed for nausea. She was sent home with Levaquin for 2 more days. She received 1 dose during the procedure. She was given a prescription for PPI for 1 month. She was also given a prescription for simethicone as needed for gas-type pains, Miralax also for constipation as needed, as well as liquid codeine for two weeks for abdominal pain and discomfort. The diet that we give our patients are clear liquids for 3 days, followed by full liquids for 11 days. So that makes the first 2 weeks. And then the last 2 weeks of the month, the patients adhere to a soft diet. 1 month after the procedure, we check an upper GI series to look at the integrity of the sleeve. As you can see here, the contrast is passing through the esophagus into the fundus. So you can see that the fundus is intact. You can then see that the contrast is passing through this narrow central body of the stomach into the portion of the sleeve that we sutured, and then going into the antrum here. So this is a very nice upper GI of what a stomach looks like after the endoscopic sleeve procedure. At 1 month follow-up, the patient was doing well with no complaints. If you remember, her weight prior to the procedure was 210 pounds, and at 1 month follow-up, she was down to 187 pounds, and her BMI reduced from 37 down to 33.